This paper will be presented by Dr. Wesnes from Norway. Their paper is Delivery Parameters and Urinary Incontinence 6 months postpartum. Thank you, Dr. Wesnes.
My name is Stian Wesnes. I would like to thank the ICS for letting us present our study, Delivery Parameters and Urinary Incontinence 6 months postpartum. Parity and vaginal delivery are established risk factors for urinary incontinence among women, but still the mechanisms are not quite clear. We do not know why vaginal delivery increases risk of urinary incontinence compared to cesarean section. It is believed that the mechanism goes through trauma to the pelvic floor, but this is not quite clear. Several risk factors have been suggested. To mention some: head circumference, birth weight, epidural, rupture, episiotomy, forceps, vacuum, prolonged labor, active pushing, and so on. Regarding pretty much all of these risk factors, there exists to a large degree inconsistency. And several reviews confirm this inconsistency, and the reviews also question whether trauma to the pelvic floor actually is associated with urinary incontinence. And they also report need for more research to clarify the role of delivery parameters on urinary incontinence postpartum. That's why the aim of our study is to investigate the association between delivery parameters and incident urinary incontinence 6 months postpartum. We used the Norwegian mother and child cohort study, which is a comprehensive birth cohort, enrolling 100,000 pregnant women during pregnancy and following them up for several years after birth. We used questionnaire 1, answered in week 15, questionnaire 2, answered in week 30, and questionnaire 3, answered 6 months postpartum. Women report continence status before pregnancy in questionnaire 1. They report the present continence status in questionnaire 2 and questionnaire 3. We have validated delivery parameters collected from the Medical Birth Registry of Norway, which has extensive information on all births in Norway back to 1967. We enrolled only women who reported being continent before pregnancy and continent during pregnancy to see how these delivery parameters were associated with incident urinary incontinence 6 months postpartum. Our study population thereby consisted of 7,561 premenopausal women who were continent before pregnancy and continent during pregnancy. We look into birth weight, head circumference, episiotomy, epidural, rupture, prolonged labor, fetal presentation, forceps, and vacuum. We perform adjusted analysis. We stratified for mode of delivery. And we looked at single delivery parameters and also looked at combinations of delivery parameters to see if that could explain the increased risk of urinary incontinence 6 months postpartum. In stratified analysis on mode of delivery, these parameters were not associated with urinary incontinence in adjusted analysis. Sphincter rupture, prolonged labor, just to mention sphincter rupture, grade 3 to 4, that is. Prolonged labor, epidural, episiotomy, fetal presentation, head circumference, and vacuum were not associated with urinary incontinence. However, we found an association with birth weights. Birth weight between 3,541 grams to 4,180 grams led to a significantly increased adjusted odds ratio of 1.4 for incident urinary incontinence 6 months postpartum. And birth weight above 4,180 grams led to a significantly increased odds ratio of 1.6. We also found an association with forceps that led to an increased risk of 1.4. Thereafter, we stratified for mode of delivery and performed combined analysis on the different delivery parameters in different ways, and in general, risks were not increased compared to analysis on the single delivery parameters. However, there were a few exceptions that I will present. We find that vaginal delivery, in combination with birth weight, above 3,541 grams, and large head circumference, above 36 centimeters, that is the 50th percentile, led to an odds ratio of about 1.6, compared to birth weight and head circumference below these numbers. Forceps delivery and birth weight above 3,541 grams led to an odds ratio of 2.3, compared to vaginal delivery and birth weight below this measure. Forceps delivery and prolonged labor led to an odds ratio of 1.9 compared to vaginal delivery and no prolonged labor. Acute cesarean section, large head circumference above 36 centimeters, and prolonged labor led to an odds ratio, significantly increased odds ratio of 1.6 compared to head circumference below this and no prolonged labor. And finally, we found that vaginal delivery, birth weight above 3,541 grams, and episiotomy led to an odds ratio of 1.5 compared to birth weight below this and no episiotomy. And what's interesting about this last finding is that if we look at women with vaginal delivery, birth weight above 3,541 grams, and no episiotomy, there was an odds ratio of 1.2. If they had episiotomy, there was an odds ratio of 1.6, and there's a significantly increased risk of urinary incontinence after birth weight above 3,541 grams if they had episiotomy. This is called effect modification. So in conclusion, you can say the high birth weight itself and forceps delivery itself increase risk of urinary incontinence postpartum. We find that risk for urinary incontinence after delivering a child of more than 3,541 grams is significantly enhanced when episiotomy is made. But we have to conclude that the combination of risk factors that we have investigated do not explain the increased risk of urinary incontinence after vaginal delivery. Thank you.
Thank you. This paper is now open for question.
Kerry Slazen from Aberdeen again. That was a very nice study, and obviously you have the benefit of very large numbers, which is wonderful. But can you explain to me why you lumped all the birth weights under 3,500 grams together? Did you not consider having a low birth weight category separately to include in your analyses?
We started out splitting birth weight into the 50 and the 90 percentile for birth weights to see if birth weight above the average and extreme birth weight were associated with urinary incontinence. But due to the exposure in the study combining women with high birth weight, prolonged labor, and maybe episiotomy and then forceps, the number of women were too small, so we couldn't restrict the birth weight category to, like, say, the 10th percentile or the 90th percentile, because the number would actually be too small.
But you could have excluded the under the 90th centile, couldn't you, or at least taken them out of the analysis?
We could have done that. We haven't performed that.
Yes, please.
Please. Yes, Arnaud Fauconnier from France. Nice card, yes. I wonder why you choose to exclude incontinent women before pregnancy. Have you an idea what would happen if you have include all women? That is a population study.
Incontinence postpartum is referred to as a mixed bag of incontinence, starting up before pregnancy, incontinence starting up during pregnancy, and incontinence starting up postpartum. And if we want to see how the exposure is associated with the outcome, the exposure needs to come before the outcome, and that's why we only included women who were incontinent to look at incident urinary incontinence postpartum. But we haven't done analysis on all women in this research, in this study. No, we haven't.
How many women have you excluded because of incontinence before?
Yeah. We have performed several analyses on this data material, and the whole group of women in the group, for first article, was 43,000 women. That was everybody. And then in our next articles, we excluded women who were incontinent before pregnancy, leaving only women who were continent before pregnancy to look at incident urinary incontinence during pregnancy and postpartum. And then we were left with 12,000 women. And thereafter, now we include only women who were continent in pregnancy, and we are left with 7,000 women.
Chairman here, can I ask you a question, please, to your right?
Yes.
Have you looked at the effects of maternal height? Maternal height.
Yeah.
Because as you probably know, Ian Milsom from Sweden has shown that women who are less than 160 centimetres with high birth weight, their risk of incontinence and prolapse 20 years later, I've forgotten what the odds ratio is, but it's very high. Have you had a look at that in your analysis?
I have problems hearing you. You say the height of the mother.
The height of the mother, yes.
Yeah. No, we haven't done that, but we have adjusted for BMI, but we haven't looked exactly at height of mother. No, we haven't.
Kamush Fabik, your gynecologist, Czech Republic. In your first analysis, you said that the risk factor is the birth weight and head circumference is not a risk factor. But it's absolutely obvious that the head circumference is associated with the birth weight. So could you comment on this? Isn't that just calculation kind of bias or not the real finding?
That might be. We see that the combination of high birth weight and high head circumference, when we did the combined analysis, led to increased risk of urinary incontinence. But this is one of the myths that we're trying to explore, because everybody says that rupture is associated with incontinence and episiotomy and head circumference. But in this analysis, we did not find it. But of course, it can be confounded by indication that could affect our material, of course.
Marie Edström, gynecologist from Norway. Hello? Here? Thank you for a very clear presentation. I really appreciated that. Do you have any explanation or theory about why the episiotomy would increase the risk of incontinence? Have you thought about that?
I have decided not to jump into making hypothesis on why on our findings. No, I haven't got a theory on that, and that would be up to basic science to find out what the cause might be. No, I'm not sure.
You're a very wise man. Thank you.
Could I ask a question? Excuse me, I'm on this side. All right. Meera Lal from the United Kingdom, and I'm an obstetrician gynecologist. Thank you very much for your interesting talk. I did a post-membership PhD on biopsychosocial effect of pelvic floor dysfunction, and some of your findings agree with my findings, though a smaller sample. Head circumference in relation to elective section was also found to be a risk factor. Do you have any data on that? And the second thing I wanted to say is that in prolonged labor, the practice in Britain, in many hospitals, is even if they are fully dilated, they wait for the head to come down before they ask the woman to push. And that may be a factor, in my case, which showed that prolonged labor was associated in some cases and not in others, depending on the obstetric practice in the hospital. Do you have any data on that?
We have stratified for mode of delivery, and we performed analysis on vacuum forceps, spontaneous vaginal delivery, cesarean, acute cesarean, and elective cesarean section. And we did not find an association with head circumference and cesarean section and urinary incontinence postpartum. So we did not find an association with that. We have only got the data from the medical birth registry. So if I understand you correctly, you ask at what phase during delivery they start pushing? Is that
yes, I mean, that may be a practice.
Yeah.
Different obstetric practice may be related to the association between prolonged labor and incontinence.
Sorry, I haven't got data on that.
Okay, thank you.
Thank you. And last question, please.
Okay. Just elaborating a little bit on the previous questions. My question would be, why haven't you done a multivariable analysis? Because it's absolutely obvious that many of the parameters that you have used are interconnected. And only by doing a multivariable analysis you can come up with the real independent risk factors. So why haven't you done a multivariate analysis?
We have done multivariable analysis, multi-regression analysis, which didn't turn out. But what we wanted to see is it's put forward hypotheses that, as I mentioned, head circumference, rupture, episiotomy as risk factors, and we wanted to look at them isolated and in combinations.
Yeah,
but
so
of course, there might be more interactions.
How did it come out in the multivariable analysis then?
Sorry?
How did it come out in the multivariable analysis? Which one of the two were
head circumference? No, birth weights were the one that stuck out, and the other did not stick out. Surprisingly, but they didn't stick out, as I referred to in the presentation.
Okay. Good.
Thank you for your questions and your presentation.